First off, ValueOptions, who we are. We are a health improvement company that specializes in mental and emotional well-being and recovery. And by that, we're not just a company that manages mental health care, but actually we have spent a lot of our efforts, our core competence, as putting into systems to prevent disease. We're expanding our health and well-being services, and I really feel as genetic testing matures, and I really do think it will mature fairly quickly over the next decade or so, we're going to be seeing a need for a lot of preventative interventions up front and behavioral changes that will need to occur in people to prevent them from getting illnesses. So you might see people kind of really seeking out these kind of preventative interventions first rather than coming in because they're sick. And so we're really working very diligently to expand our health and well-being services. We also have employee assistance services, and we also do mental health and utilization services. We have three major markets: commercial market, state, local government market, and federal market. Prevalence of behavioral health. I think we're all aware, keenly aware over the past year or two of things that have gone on around the country, just of the prevalence of mental illness and the impact on society as a whole, and also the undertreating of mental illness. You know, mental health direct expenditures is about 7% of total healthcare expenditures, but if you really look at health as a whole, mental health does impact probably about 30% of all medical spend. You know, about half the people over their lifetime will have mental illness at one point. Suicide is really increasing significantly, especially in the military population. As you can see here, that less than 1% of the U.S. population, the veterans, represent about 20% of suicides nationally. There's a significant economic impact of behavioral illness that is also experienced throughout healthcare. Addiction treatment alone contributes to or directly causes over 70 different medical illnesses. 1/3 of all hospital costs are associated and attributable to addictive illnesses. We're also seeing in healthcare exchanges, especially in the population 18 to 26, significant incidents of untreated substance abuse problems as well as mental health problems. And we see that as being kind of an issue that really need to be addressed over time as the exchanges kind of activate throughout the country. What I'm going to talk to you about is an initiative that we did here with a Virginia-based employer on a disease management, where we partnered with the medical plan to engage members who had chronic diseases and diseases such as diabetes, asthma, cardiac diseases, and chronic pain. And they were screened on the medical side with a brief 2-questionnaire depression screening tool, as well as kind of looking at claims data for past treatment of depression or past treatment of mental health. And they were referred to our intensive case managers. It was a voluntary service. So they were transferred to us for engagement telephonically, and these members typically were sporadically compliant with their medical treatment, poorly engaged, had very high cost medical readmissions, but nonetheless were agreeable to kind of participate with telephone conversations with our intensive case managers. Our initial contact with the member, we did a depression screening at PHQ-9, for those who know what that is. It's basically a rough screening tool to judge the gauge of depression. You can see most of the members were in the moderate phase of depression, some mild, and had about 8% none. And we engaged the members and retested them after 6 months. And what I'm talking about here, we had about 600 people in the study. We had about 200 people that actually completed the depression tests, and we had about 400 people that actually completed what we call the financial part of the study, where we judged the claims before and then after engagement. So you can see this is really showing kind of what happened kind of with the telephonic intervention with the intensive case manager 6 months post-treatment. And we saw a significant reduction in depression scores, about 36% less. We actually saw the biggest reduction in people with more severe depression. We saw about a 63% drop in scores. The most interesting thing was we saw a significant cost savings. We had about a $1.2 million reduction in total claims cost on medical and behavioral side 6 months after intervention. And our claims savings were $2.40 for every dollar we spent in the program. And this could be underestimated because we only followed the claims out for 6 months. And all the people we brought into our program were people with chronic disease that we think over time, actually the cost, if the engagement kind of continues and continues long-standing, actually would be greater than this. And I think it's helpful to know because I think one of the key things with healthcare now is that members really to purchase value are not just purchasing treatment of a condition, but I think the key thing we engage members in is to really improve the quality of their lives. If we can make the connection with improvement in quality of life to the treatment of that condition and engage the member in some meaningful kind of forward movement in their life, and we can help them tie that into the treatment of whatever illness they're not effectively treating, that's when we feel people can move forward. And I'm illustrating a few cases here. Here's a case, I think it's helpful to go through this. Is a 52-year-old male with depression, anxiety, diabetes, coronary artery disease. That's kind of how it's looked at typically. This person needs to be compliant with his medications, needs treatment, and he's not. Why? We assessed him and we found out he had a nine-year-old and a 13-year-old daughter. The youngest daughter was declining in self-care. She refused to go to school. The entire family was grieving the loss of a mother who kind of kept the whole family together. He was not taking his medications, saying he was too overwhelmed, didn't have time to do it. He didn't have any substance abuse issues. And he was recently divorced. So the interventions included, over time, kind of motivating him through repeated calls to engage with EAP services. That transitioned to outgoing support for his members and his daughters. That ultimately led to family therapy, also led to involvement with the school counselor to help the daughter's behavioral problems. The member was referred to a single parenting group, which he benefited from greatly. And then over time, he agreed then to be connected to his diabetic nurse. And he followed up with his program for diabetes, had significant weight loss, and also was connected with financial planners through the EAP service that helped him with his finances. His last PHQ score was 3, indicating no depression. And he had an excellent outcome really from kind of engaging in initially motivational interviewing and also having a care manager who kind of knew the pieces of healthcare and could connect him to all the services that he needed. The second case is a 48-year-old female who's referred from our medical provider's diabetes program. She did have a history of depression, history of PTSD, diabetes, chronic pain, gum disease. She consented to the care coordination telephonically. And it was really revealed that she was extremely depressed. She hardly left her house except for doctor's appointments. She was not bathing. She was in need of dental care, which she neglected, which resulted in some dental extractions. But she did have good relationships with her spouse and had an 11-year-old son who basically, because of her impairment, was cared for by her grandparents. We were successful in our interventions with connecting her to an outpatient therapist and a psychiatrist. Medications were adjusted. She was able to reach her goals. Activity levels and socialization occurred. She became interested in photography again, and going out of the house with friends. And then she also was agreeable to a referral to the diabetes nurse and the medical program for management of her chronic diabetes, which she readily accepted. And this was after kind of the emotional kind of changes occurred positively. Then we kind of really pushed the medical involvement. And we had a very successful engagement. She lost 60 pounds, began exercising, and reduced her. She was also on pain medication, was able to successfully reduce them significantly with contact with her pain management doctor. And her PHQ score decreased significantly to only mild depression. I think all of these things really kind of reinforce what we feel is kind of a campaign that, well, it's a campaign that ValueOptions is actively pushing to stamp out stigma. In both these cases, none of these people really knew what was going on with them. None of these consumers really knew that they were depressed. But not only that, they did not realize that their depression could be treated and they could get better. So we have over the past year, and we have a booth upstairs. Lynn, are you here? Lynn's at the booth for ValueOptions. You can stop by and check out our Stamp Out Stigma campaign. We're really trying to recognize, re-educate, and reduce the symptoms of depression and mental illness in general.